Good afternoon. Welcome everyone to the Senate Committee on Health and Human Services. Madam Secretary, please call the roll.
Senator Lang. Here. Senator Wynn. Here. Senator Titus. Here. Senator Stone. Chair Donate.
And I am here. All members are present. Good afternoon, everyone. Sorry again for starting a few minutes late. Some of us were coming from other committee meetings. But today we have an exciting day. We have reached the first deadline of the session so far for at least our side. We will have a work session for a few bills followed by a hearing on Senate Bill 365. We know that there were several agenda items that listed other bills. Those bills will not be heard today, so we will only hear Senate Bill 365, and we will do the work session. I do have a few housekeeping announcements. If you choose to participate for the hearing later today, just know that the same way as always, we ask that public comments be kept to 2 minutes each so that everyone interested can be accommodated. For the sake of time today, we will limit testimony to 2 minutes, as I mentioned. If you can't make it within that time frame, you can always feel free to share your additional testimony or your testimony in writing to our committee staff. When testifying, please turn the microphones on to speak and off to listen. And we have listeners and viewers in Las Vegas. And then anyone who wishes to receive copies of the committee's exhibits should go to the Nevada Legislature's website. And finally, we ask everyone if they can please turn off their electronic devices. Let's begin with the work session. So we're going to start with the work session on a few bills. So just give me 1 second. So we'll start with Senate Bill 118. Members, as you remember, we had this bill presentation a few weeks ago, and we work sessioned it on the same day. But we did have an additional amendment added to the Senate Bill 118 that was not mentioned during the bill hearing or for the work session. So the procedure right now is to accept a motion to reconsider so that we can attach the additional amendment. So I'll go ahead and accept a motion right now to reconsider Senate Bill 118.
I'd so move.
We have a motion from Vice Chair Wynn. Do we have a second? Second. We have a second from Senator Titus. All right. Now we will go ahead and accept. So let's have Ms. Cooper discuss the amendment, and then we'll do the motion for accepting the amendment.
Destiny Cooper, Research Division, Legislative Counsel Bureau. There was an amendment proposed on the day of the hearing, so this is just going to go over the additional amendment. The intention of this amendment replaces the one-time appropriation of $15 million in each of the year 2023-2025 biennium with an ongoing allocation of flexible funding to state and local public health authorities distributed annually on per capita basis.
All right, so we're still on the motion to reconsider. So once again, we have a first from Vice Chair Wynn, a second from Senator Titus. All those in favor, please say aye.
Discussion.
Oh, this is just for the motion to reconsider. So for the motion to reconsider, all those in favor, please say aye.
Aye.
Any opposed? Motion's carried. All right, now we will accept a motion to amend and do pass with the amendments supplied by Washoe County for SB 118. Do we have a motion for that?
I would move.
We have a motion from Vice Chair Wynn. Do we have a second?
Second.
Second from Senator Lang. All right, now we can have discussion and questions.
Excellent, thank
Senator
you.
Titus.
So during the hearing, I brought up that I felt 45 days was not enough, and that they agreed that we had to follow what probably the federal guideline was. And in the amendment I'm seeing here, they did say 45 days to 90 days per my request. But then I just heard our staff say that the amendment only replaces the $15 million to a flexible funding, but it does 45 to 92, correct?
That's correct. It's an additional amendment.
Okay, good,
So
thank you. I just wanted to.
the portion that we received from Washoe County, and we also have representatives if they want to speak on the amendment as well, is also attached for the work session.
I just want to make sure that 90 days was where they had settled.
That's correct.
Thank you.
Yep.
Very much.
And the amendment, just to clarify, is for the distribution and apportionment of money collected for this particular bill. So again, the motion is to amend and do pass with also the amendment supplied by Washoe County. So it's to accept both amendments for Senate Bill 118. Any other further discussion? All those in favor, please say aye. Aye. Any opposition? Motion's carried. I will go ahead and take that floor statement again. So thank you so much. Let's move on to Senate Bill 161. Ms. Cooper.
Destiny Cooper, Research Division. Senate Bill 161 was heard on March 2nd, 2023. It requires the Department of Health and Human Services, to the extent authorized by federal law, to allow recipients of benefits from the Supplemental Nutrition Assistance Program or the Special Supplemental Nutrition Program Assistance Program for women, infants, and children to use those benefits to purchase menstrual products. The department must take any action necessary to obtain federal authorization to carry out these provisions. The amendment proposed by Senator Doniate expressly provides that the bill provisions apply only to the extent that federal funds are available. Thank you.
Thank you, Ms. Cooper. Any questions on the amendment or to the bill? Seeing none, I will go ahead and take a motion to amend and do pass SB 16. Vice Chair Nguyen's motion and seconded from Senator Stone. Any discussion on the bill? All those in favor, please say aye. Aye. Any opposition? Motion's carried. We'll sign that floor statement to Senator Scheibel. Moving on to Senate Bill 192. Ms. Cooper.
Destiny Cooper, Senate Bill 192 was heard on April 11th. It changes the name of a hospital advisory board to a hospital governing board and requires such a board to adopt bylaws and related policies and procedures. Additionally, this bill extends the types of topics that may be discussed in a closed meeting of a board of hospital trustees or a hospital governing board to include several provisions. The amendment proposed by University Medical Center proposed an amendment to clarify that SB 192 is not intended to impact the ultimate discovery of information sought in any lawsuit or broaden the evidentiary peer review privilege. Thank you.
Thank you so much. Any questions on this bill? We'll go ahead and take a motion to amend and do pass.
I'd so move, amend, and do pass.
We have a motion from Vice Chair Nguyen. Do we have a second? Second from Senator Titus. Any discussion on this bill? All those in favor, please say aye. Aye. Any opposition? The motion passes for amend and do pass, and I'll sign that floor statement to myself. Moving on to Senate Bill 241. Ms. Cooper.
Destiny Cooper, for the record. Senate Bill 241 was heard on March 21st. It requires the Director of the Department of Health and Human Services to include in the state plan for Medicaid, to the extent that federal financial participation is available, a requirement that the state must A, pay the non-federal share of expenditures for outpatient and swing bed services provided at critical access hospitals, and reimburse a critical access hospital for such services at a rate equal to the actual cost of providing the services. Thank you.
Thank you so much. Do we have any questions on this? We have a motion for amend. This one is do pass. Do we have a motion?
Motion to do pass.
We have a motion to do pass from Vice Chair Nguyen. Do we have a second from Senator Lang? Any discussion?
Yeah,
Senator
comment. This is a
Titus.
great bill. Please support. Thank you.
It's a very good bill. Let's go ahead and call it to a vote. All those in favor, please say aye. Aye. Any opposition? Motion's carried. And because it's a really good bill, we'll give it to Senator Titus for the floor statement. Let's move on to Senate Bill 242.
Destiny Cooper, for the record. Senate Bill 242 was heard on March 23rd, 2023. Since then, the bill has basically been redone and changed, so I will just go through the amendment without summarizing the previous bill. Proposed by Scott Rutledge with Argentum Partners, the proposed amendment removes the bill's original provisions and instead of directing the DHHS to establish a psychedelic medicines working group to review research, laws, regulations, and programs pertaining to the therapeutic use of certain entheogens and compounds, including psilocybin and psilocin. The 15-member working group must develop a plan for enabling access to such substances and report it to the findings to the 2025 legislature. Thank you.
Thank you so much. So the motion for this one is amend and do pass SB 242. Do we have a motion?
So move.
We have a motion from Vice Chair Nguyen and a second from Senator Stone. Any discussion? Senator Titus.
So thank you for this, and thank you, Senator Nguyen, for the amendments and hearing a lot of our concerns. I unfortunately am not going to be able to support this, and it's all about what the intent of the amendments is still to look at how can we use this, what can we do to make this happen. So unfortunately, I will not be able to support this bill. Thank you.
Thank you so much. Any other discussion? Senator Stone.
Thank you, Mr. Chair. While I always like to be congruent with my fellow colleague, Dr. Titus, on the committee, I want to applaud the author for addressing the efficacy of microdosing of psilocybin and other ingredients of magic mushrooms. I really believe that there is benefits that have been revealed. We just need to refine some studies and show that people with PTSD, some people with depression, and other psychiatric issues can benefit from our investigations. And so this is a step, I think, in the right direction, and I look forward to working with the author as a co-author and hopefully getting some very positive results from our inquiries and maybe providing some relief for some very severe diseases, if you will, PTSD, people that are coming back from war, and give them the relief that conventional medications have not been able to deliver on. So I applaud the author, and I look forward to working with her.
Vice Chair Nguyen?
Thank you, Senator Stone. And I just, I appreciate all those people that reached out. It was amazing how many people this bill has touched. People that have not participated in the political process, people whose lives they credit from these like medicines and these therapies. And I look forward to what comes out of this bill and what comes out of the research and the direction that we can use with this working group during the interim. So thank you. I hope everyone supports it.
Thank you, Senator Nguyen. Before I call it for a vote, I don't have any mushroom puns, but I just did want to express, Vice Chair Nguyen has spent a lot of hours on this bill. It's a historic moment for our state that many community folks we saw come forward for the first time, and so I think a lot of us are graciously appreciative of all her efforts. So moving that, let's go ahead and call it to a vote. All those in favor to amend and do pass Senate Bill 242, please say aye. Aye. Any opposed?
Nay.
We have one nay from Senator Titus. The motion's carried, and I'll go ahead and assign that floor statement to Senator Nguyen. Moving on to Senate Bill 298, Ms. Cooper.
Destiny Cooper, for the record, Senate Bill 298 was heard on March 30th. It contains various provisions related to the involuntary discharge of a resident of a residential facility for certain groups. Among other items, the bill prohibits the owner, agent, or employee of a residential facility for groups or a provider of health care from acting as a representative of a resident in matters concerning the involuntary discharge of the resident unless the person is related to the resident. There were amendments proposed, and they can be found attached. Thank you.
Thank you so much. Any questions on this bill? For this one, it's amend and do pass, so I'll go ahead and accept the motion.
I move.
We have a motion from Vice Chair Nguyen to amend and do pass SB 298. Any seconds? Second from Senator Lang. Any discussion? Senator Titus.
Thank you, Mr. Chair, and unfortunately, I will not be able to support this bill. I feel there's many times that facilities are forced to make decisions, and this, I think, is going to be a very cumbersome process and with unintended consequences, and so I cannot support this bill. Thank you.
Thank you so much. Any other comments? Senator Stone.
Thank you, Mr. Chair. I regret that I can't support the bill today as well. I think if a client cannot pay, that this bill will prohibit the involuntary discharge, creating an unfunded mandate for the home. If the state were to assume the financial responsibility of the patient, I could probably support the bill, but it should not be on the homes that have to basically hold on to a client, putting them at a financial disadvantage and not being able to properly find an alternative home for them. So for those reasons, I have to oppose.
Thank you so much. I did want to make a quick clarification. We did accept an amendment from Mr. Solomon, who is CEO of the Nevada Healthcare Association, for the discussions on how the transfer would be required. And the provisions that I stroked from this bill, would be from the perspective of what we do in emergency cases and then also the hearings process. So those are the later sections of the bill. I felt that was an important discussion to keep the bill moving forward because there are some provisions. And so we'll have further discussions as to where the jurisdiction lies for those folks that find themselves in this situation. But that's where the bill lands. So again, this is a motion to amend and do pass. All those in favor, please say aye. Aye. Any opposed?
Nay.
We have 2 nays from Senator Stone and Senator Titus. The motion's carried, and I'll go ahead and take that floor statement. Let's move on to Senate Bill 348. Ms. Cooper.
Destiny Cooper for the record. Senate Bill 348 was heard on April 6th. It requires a person to obtain the written approval of the Director of the Department of Health and Human Services before closing or converting a hospital into a different type of health facility. This bill additionally requires a person to obtain the written approval of the director before establishing an independent center for emergency medical care within 15 miles of another emergency care center or a hospital. The department and the Division of Public and Behavioral Health are authorized to impose certain civil penalties and take other disciplinary actions against those who fail to comply. Thank you.
Thank you so much. Any questions on this amendment? Seeing none, the motion for this one is amend and do pass. I'll take a motion right now.
I'd so move.
Vice Chair Nguyen has made the motion for amend and do pass. Do I have a second? Second from Senator Lang. Any discussion? Senator Titus.
Thank you, Chair. This is a bill that I absolutely cannot support, although I know that it's personal to you, that it came about from an incident in your communities. I feel it's going to have significant unintended consequences. And really the fact that they're going to have mandatory 2 licenses, not only increase fees, but it may actually disrupt the transfer of patients by having that requirement. It may actually end up costing patients more. And if a facility can't make it viable as a full hospital in an area, at least an emergency service there can save lives, better than nothing at all. So with that, I regret that I cannot support this. Thank you very much.
Thank you, Senator Titus. Any other discussions on the motion? Again, this is for amend and do pass SB 348. All right, moving on to the vote. All those in favor, please say aye. Aye. Any opposition?
Nay.
We have a opposition from Senator Stone and Senator Titus. The motion's carried, and I'll go ahead and take that floor statement. Moving on to Senate Bill 385, Ms. Cooper.
Destiny Cooper. Senate Bill 385 was heard on April 11th. Senate Bill 385 requires a hospital that discharges a patient to establish a team of healthcare providers, including a dietitian, to assist in the caring for the patient during rehabilitation at his or her residence. Further, the primary care physician of a patient at a hospital must document reasons why any customary tests were not ordered or conducted. Additionally, the bill requires the Director of the Department of Health and Human Services to include in the state plan for Medicaid a requirement that the state pay the non-federal share of expenses for the filing of cavities and the fabrication, preparation, and placement of temporary or permanent crowns. The department must also apply for the federal approval necessary to provide such coverage. The amendment was proposed during the bill hearing. I do want to mention that there was an additional one added after. It is number 5 and amend section 9 subsection 1 to add a paragraph to include coverage of removable dentures to improve mastication function, phonetics, and aesthetics. Thank you.
Thank you so much. Any questions on this bill? This is a motion for amend do pass. I'll go ahead and entertain a motion.
I'd so move to amend and do pass.
We have a motion from Vice Chair Nguyen. Do we have a second? Second from Senator Lang. Any discussions? Senator Stone.
Thank you, Mr. Chair. I regret I can't support the bill today, although there are some provisions of this bill that I like. Providing dental care for Medicaid beneficiaries, I think is a very good provision. But as you know, we have a shortage of healthcare professionals here in Nevada, and certainly dietitians is one of them. And I think if a dietitian was needed, I think a physician would make such an order. And then I think that if a patient requests tests and the doctor doesn't feel that the test is necessary, I think it could yield more malpractice cases against physicians, or if they try to avoid malpractice claims, they may order some very expensive tests that are going to raise the costs for insurance premiums for all of us to pay for those maybe tests that weren't exactly needed. So for those reasons, I stand opposed today.
Thank you so much, Senator Titus.
Thank you, Chair. I echo what my colleague has just stated with the fact that it may also delay a good discharge, trying to arrange for some of the stuff that just simply isn't available. And there's not clear on, does it have to be done at the time of discharge before they can be seen by a dietitian? Our dietitian might come once a month in some of these rural hospitals, and so is that going to delay the discharge? And it's really unclear, well-intended, but it's that access issue that I'm concerned about, not that several components of this bill aren't a good idea. But again, it's these unintended consequences, the potential for lawsuits, and at the end of the day, not achieve what they're really trying to do. So thank you, but I'm going to have to be a no.
Thank you so much, Senator Titus. Any other discussions on this motion? Once again, it's a motion for amend and do pass SB 385. All those in favor, please say aye.
Aye.
Aye. Any opposition? We have a nay from Senator Stone and Senator Titus. The motion's carried, and I'll assign that floor statement to Senator Neal. Moving on to Senate Bill 419. Ms. Cooper.
Destiny Cooper for the record. Senate Bill 419 was heard on March 28th. It makes various provisions relating to public health, among other items. The bill requires the Department of Health and Human Services to adopt a framework for the electronic maintenance, transmittal, and exchange of certain health information, and with certain exceptions, requires relevant entities to come into accordance with that framework beginning in July 2024 or July 2025, depending on the type of entity. Outlines related provisions concerning grants, waivers, and noncompliance with the framework, expands an existing immunity from liability to apply to any healthcare provider who transmits, accesses, utilizes, or discloses an apparently genuine electronic health record, establishes within DHHS the Nevada Innovation Hub, headed by the Chief Data Officer, to obtain public health information from pertinent entities and establish a program to collect, analyze, and make available such information. Authorizes a person who intends to locate or expand a business in an academic medical district to apply for a partial tax abatement, which must be granted under certain conditions. Requires the Director of DHHS to include in the State Plan for Medicaid authorization for any person who otherwise qualifies for Medicaid to enroll in the program regardless to his or her immigration or citizenship status. There are other provisions that are mentioned in this bill. It's quite lengthy. I do just want to briefly go over the attached amendment. Senator Doniate proposed an amendment to revise sections 1, 24, 31, 39, 61, and 62, and to add certain language as shown in the attached amendment. Thank you.
Thank you, Ms. Cooper. Do we have any questions from any committee members at this time? Vice Chair Nguyen.
Oh, I don't.
Oh, do we have any questions on the amendment? No. Again, this motion is to amend and do pass Senate Bill 419. Vice Chair Nguyen.
May I make a motion to amend and do pass?
Thank you so much. Do we have a second? Second. Seconded by Senator Lang. Any discussion on this motion? Senator Titus.
Thank you, Chair. I want to acknowledge that you are truly looking out for your constituents and the people that you hold dear, and you want to make sure that they have good and adequate and accessible health care. I, in turn, am looking out for my constituents also, and I feel that this bill dramatically dilutes the supply of what we have, the accessibility, and frankly, of all the bills we've heard this session, this particular bill I've heard more from than any other bill, which is pretty amazing, actually. But I know what you're trying to do. Unfortunately, I think it causes more harm than good. We need to work out supply chain and access to care, but this is going to, I think, do the reverse. So I have to be a no. Thank you.
Thank you, Senator Titus. Senator Stone.
Thank you, Mr. Chair, and I also want to compliment you. This is a very challenging issue, a very contentious issue, a very divisive issue. Not that you're trying to create division. I know you're not. You're trying to find solutions, and I always appreciate you thinking out of the box and coming up with solutions. But I guess I could say that coming from another state that has done this, and I know you've tailored your bill to a much smaller population. If you look at the demographics of the state of California where I served, you're going to see that you've seen the flight of people that have resources leaving the state, and those people that are seeking services are coming to the state. So if you look at the expenditure for undocumented immigrants moving into California and taking those benefits, it's been dramatic. And California is looking at between a $20 and $40 billion deficit this year, which they're going to have to address. I, like my physician colleague to my right, has received a lot of emails, not just about giving benefits to undocumented people, but very concerned about medical records and sharing of data that they want to have permission to give that data. So I think this is a real omnibus effort on behalf of the chair, which again I applaud him on, but it's going to probably have to be taken in different slices so that we can really address the safety of medical records to ensure HIPAA. Like my colleague, we have one of the lowest Medicaid fees in the country, And we as a state, and I say this with fond criticism, or unfond criticism, I guess, that for every dollar that we can put up, we get like $3 back from the federal government. And I haven't understood why Nevada doesn't put out more money so we can get more money back to make sure that we have true access for people that need the services, especially those low income people. So now we potentially, of course, it's been amended, but we were looking at possibly adding 95,000 more people to the rolls. And we have people that are having access troubles today. So I'm hoping that in the future that the state puts out a larger expenditure for Medicaid, so we get more money back from the federal government, so we can get physicians that will take Medicaid, so we can reduce the access issues that our citizens are encountering. And listen, I'm all about philanthropy. And I think this is a philanthropic effort if we want to give benefits to those that are undocumented, but I believe we need to take care of our citizens first before we get into the philanthropy that is important to many of us sitting on this dais. So again, I want to applaud the author. Can't support the bill today, but I know it's going to have other iterations probably by the time we may see it again when it comes back from the Assembly, and I look forward to seeing what happens to the bill as it moves forward. Thank you.
Thank you, Senator Stone. Vice Chair Nguyen.
Thank you. I just want to say that I support this. We were all elected by our various constituents to be here and sit here and make decisions. But when we get here, we don't make just decisions for our constituency base. We make policy for the entire state. And I appreciate what is often lost in politics and sometimes is lost in policymaking is that humanity and hope. And so I believe that this bill, Senate Bill 419, reminds us of our humanity, reminds us that we are all humans, reminds us that we are making policy for the betterment of our entire state. And I think that's exactly what this bill does. And with that, I hope everyone would support this bill.
Thank you, Vice Chair Nguyen. Any other discussions? I want to make a few comments before we move on to this work session. And it's important for me to also address some of the sentiments that we've seen with this bill. Let me make some clarifications for everyone. This bill does not change the opt-in requirements for the exchange of health information. That is a concern that we have seen from the community, and it has not been changed for this bill. There are no questions with regard to data privacy. We still have to oblige by HIPAA laws, just as how has been preferenced by federal statutes. This bill does not supersede that, nor does it change it. It just allows you and your provider to connect, and it allows them to connect with other providers, so that if you have a situation at one hospital, your doctor has access to that information and can help you out. I also want to clarify other sentiments. In the research that we've seen from California and Oregon and other states that have considered this, there has been no change to the immigration status of folks that have moved in for services. That is not something that has been evident in the recent research that has been displayed. I know this is a tough issue for many of us. I know that folks share their sentiments because oftentimes we think of this issue as, well, if we give some resources to some people, then we're taking away resources from others. Here's the reality of this situation. These individuals, the people who are undocumented in this state, are taxpayers. I've spent a lot of time, and I was talking to our vice chair earlier today, thinking about what makes someone a Nevadan. Is it someone that just moved here about a month ago and changed their license? Is it someone that was born here? I wasn't born here. I moved here when I was 2. I was born in California. I consider myself a Nevadan. My family members, those who are undocumented, have lived here longer than I've been alive. They are Nevadans. They call this place home. They pay taxes. They pay sales taxes. They pay property taxes. They pay taxes all across this state. And so when I think about the government services that the taxpayers pay for, and when we deny them the ability to receive these government services, it questions to us, why have we developed these artificial barriers when if they are Nevadans and they call this place their home? What are the intrinsic motivations between the hateful rhetoric that we display with one another and we deny people the simple right to live, to receive healthcare? It's simple as that. I want to also clarify that philanthropy can't solve these problems. There was a reason why I had Cure for the Kids present this. Because when folks were denied care, kids that have cancer living in this state right now were denied care. Philanthropy had to step in, but they can't step in for everyone. The taxpayers of this state who call this place home, regardless of their immigration status, deserve access to government services. It's as simple as that. We can choose to ignore it. They're not just in my district, they're all across the state. They're your farm workers that pick your food. They're the restaurant cleaners. They're my family members. The bill amendment will allow for a Medicaid match. If you look as part of the population, I put in the bill to establish a state-funded coverage program for kids, children, and young adults from 0 to 26. This bill does not cover everyone, and I know I will fall short. I know I won't be able to help my family members. But I brought to you a proposal where kids that have cancer will finally have some hope. Where the college students that are nursing students that can't even finish their program because they need health insurance to finish their rotations will now have the chance to finish their program and become nurses. The bill also will bring us federal matches. It's what we've seen in other states. In fact, if you look at the proposed amendment, it requires our Medicaid folks to seek all necessary federal authorities to expand CHIP coverage. There are federal matches to cover folks, whether they're pregnant persons or in postpartum coverage. These programs exist. It's been enacted by Utah, Texas, Tennessee, all across the board. I showed you the map. The funds are there. We will receive benefits for it. And then, of course, I think the question that was, we don't want to provide free healthcare for these folks, even though they're taxpayers. We have denied them the ability to live. That's why in this amendment, I included a provision for them to be able to buy into the system. Because if we can't afford people the right to live, we should at least allow them the ability to pay for it. That's as simple as how this bill comes out to be. And I want to touch point on just one last point. Today, President Biden released an announcement that DACA recipients with the new federal changes will be able to receive healthcare services. That's in this bill. We have an obligation to protect the people regardless of who they are, where they come from. You know, before we call this to a vote, I think a lot of people have come up to me within this week, and they asked me about the fiscal note. And they asked me, why are you so excited to see such a big fiscal note? And I said, I'm excited because for the first time, we know how much it costs. We've never had that. So if I fall short, so what? We've made progress. Let's continue the fight. So with that, I'll go ahead and call for the vote. Again, this is on Senate Bill 419. It's for amend and do pass. All those in favor, please say aye. Aye. Any opposition?
Nay.
We have an opposition from Senator Stone and Senator Titus. The bill passes out of this committee, and I will take the floor statement. Moving on to Senate Bill 439. Ms. Cooper.
Destiny Cooper for the record. Senate Bill 439 was heard on April 11th. Senate Bill 439 makes various provisions related to communicable disease, among other items. This bill requires the development of policies to provide uninterrupted services during a public health emergency to persons who have been diagnosed with the human immunodeficiency virus or persons who are at high risk for acquiring HIV. Imposes certain requirements to ensure prisoners have access to treatment and prevention methods for HIV. Specifies that the previous repeal of certain criminal offenses related to HIV apply retroactively to the violations that occurred before the effective date of their repeal. Requires certain healthcare providers who provide emergency medical care or primary care at a hospital to complete 2 hours of training in stigma, discrimination, and unrecognized bias towards persons who have acquired or are at high risk of acquiring HIV. Revises certain provisions regarding the level of offense for a prisoner who uses human excrement or bodily fluid that contains a communicable disease with intent for the substance to come in contact with another person. There's also other provisions relating to the bill. There were 4 amendments proposed total. They were all introduced during the bill hearing, and they could be found attached. Thank you.
Thank you so much, Ms. Cooper. The motion for this one for Senate Bill 439 is amend and do pass. Do we have a motion?
I so move.
We have a motion from Vice Chair Nguyen. Do we have a second? Second from Senator Lang. Any questions or discussion? Senator Titus.
Thank you, Mr. Chair. I have to be a no on this bill. There's many components to this bill that I think are excellent, but it's the volume of the bill and certain sections that I expressed not supporting during the hearing, and because of that, again, there are certain sections that are wonderful, treatment, step therapy, et cetera, but many others in here I just cannot support, so I will be a no. Thank you.
Thank you, Senator Titus. Senator Stone.
Yeah, thank you, Mr. Chair. I respectfully will have to not vote on this bill today. In particular, I'm concerned about Section 17. I made my comments known during the hearing. Also, with regard to the continuing education classes, I think that the medical board should be the ones that require what types of CE physicians should do or not do. I don't mind the legislature giving the medical board recommendations for what the CE classes should be, but I think that should be up to the medical boards. And for those reasons, I will be opposing the bill today.
Thank you, Senator Stone. Any other discussion? Moving on to the vote of amendment to pass. All those in favor, please say aye. Aye. Any opposition? Opposition from Senator Titus and Senator Stone. Motion's carried, and I'll sign that floor statement to Senator Harris. All right. We have concluded the work session. Some of our members will step out to go to another hearings. So we'll continue with the agenda. If you give me 1 second. And we'll go ahead and open the bill hearing on Senate Bill 365. This bill revises provisions relating to the training for agents and employees of certain health facilities. We have Senator Titus to present this bill, so please begin where you're ready.
So, thank you, Chair Donate and members, although limited members of the Committee on Health and Human Services. As you probably are aware, I'm Senator Dr. Robin Titus. I represent Senate District 17. And although I know members are aware of my district, I will add for those listening that I represent Douglas County, Lyon County, Churchill County, Mineral County, Esmeralda counties, and part of Nye, specifically Tonopah. I'm here to present SB 365. SB 365 is an act relating to healthcare, revising requirements governing training and cultural competency for agents and employees of certain health facilities and providing other matters properly relating thereto. At the table with me are Dr. Susan Pintar, she is Medical Director of Eagle Valley Children's Home, and Connie McMullen, who is a lobbyist for the Personal Care Association of Nevada. In the audience, I will have two other folks who will be part of the presentation, Alan Ward and Bob Crockett will be on Zoom, correct? Okay. I brought SB 365 after many conversations with various healthcare facilities and Dr. Pintar regarding the training hours regarding cultural competency and exactly who is required to take it and what is required to be taught. To be clear, this bill, my bill, is not about removing the training. As a matter of fact, everybody at this table supports the training. What we are trying to do is get some clarification about the mandates. In 2019, the 80th session passed SB 470, which required a medical facility to conduct training related specifically to cultural competency for certain agents and employees of facilities. It did not clarify the number of hours required. In 2021, the 81st session passed AB 327, which required biennial completion of 2 hours of cultural competency for mental health providers. What SB 365 does is attempts to clarify who should have the training and how many areas are required across the healthcare spectrum. I will now turn over the presentation to Dr. Pintar.
Thank you. Thank you. Susan Pintar. I'm a pediatrician practicing here in northern Nevada for close to 100 years. Currently, I'm here as the medical director for Eagle Valley Children's Home, which is an intermediate care facility for the intellectually delayed. We provide residential nursing and medical care for children and young adults with severe disabilities. We also have a respite program, which provides in-home care to those with severe disabilities. I again, want to say that I do support the concept of cultural competency education. I think that implicit and explicit bias affects all of us. The more we are aware of that, the better physicians, nurses, and healthcare workers we're going to be, because we see people at their most vulnerable. Having said that, I am not in favor of the way that the mandatory training in cultural competency has been defined and implemented, and I believe that this bill, SB 365, will rectify those oversights, so to speak. The current bill has been interpreted to apply to every employee of a healthcare facility. Specifically, it says any agent or employee of a facility who provides care to a patient or resident of the facility. That's a very broad category. And although I think cultural competency or bias training is important for nearly everyone, I'm not sure that it should be mandated for every employee of a healthcare facility. The second concern that we have is that this training has been has been required and takes approximately 6 to 9 hours. That is an annual training. It's training that is not necessarily have to meet any of the educational requirements for physician or nursing or respiratory therapy licensure. So, for example, when I take that training, it's an additional 9 hours in addition to the 40 hours that I am mandated to take. And I think that the training should be, one, shortened, and second, it should meet the continuing medical or nursing or professional board education requirements. To put it in some of the other things in perspective, I mentioned that there's a 6 to 9 hour training required annually. My facility has about 100 employees. Those employees average between $18 and $20 an hour just across the board. So to put this in perspective, in order for every person in my facility to receive this training, we have to spend about $300 per employee per year, or about $30,000 per year, which is a non-reimbursable cost for our facility to be in compliance with the cultural competency training as it's been defined by the state health department. This obviously strains our staffing because it's a mandatory training. We have to do it on site. So that person who would be coming in for their shift, their 8 or 9 hour shift, is now doing training, and a second person has to come in to cover that shift. So that essentially doubles the cost, and that's where we come at that $18 to $20 an hour, we come to about $300 per person. So, in summary, the bill under consideration would address these grievances. It would require training for those who have direct patient care responsibilities and their supervisors. It would make the required hours of training more manageable, and it would require those training hours meet the standards for medical and nursing education. I urge your support of Bill 365. Thank you.
Thank you, Chair. Now I'll have Connie McMullen.
Thank you, Chairman Donati, and committee members. For the record, I'm Connie McMullen, and I represent the Personal Care Association of Nevada, known as PCAN, and we do support Senate Bill 365. We've been waiting for a bill like 365, and I thank the senator for bringing it. It applies for us under facilities of the dependent. Facilities for the dependent, for personal care, applies in our regard to non-medical services where everybody else under the umbrella is medical. Our services are bathing, dressing, grooming, transferring, feeding somebody. PCAN believes that cultural competency should be a part of training for caregivers. However, the curriculum that was proposed is too extensive, time-consuming, costly, and complex for the average caregiver who may only have a limited education, oftentimes high school, and care for a neighbor, a family member, and a friend. For this caregiver, it may be the only person they are providing that kind of care for while employed for a personal care agency because it is the only way they can get paid. And so, but if they're caring for a family member, what do they need to know that's culturally different? That makes no sense to me. For the personal care agency, the expense of having to train cultural competency has been financially difficult, as most of them are small businesses, mom and pops, trying to provide caregiving during a recession with low reimbursement, as we've been hearing, sometimes in our case below minimum wage, and will be even worse come this July. And during a critical workforce shortage of caregivers, this is really hard on this small business community. For the larger companies, the cost to train each employee is an unreasonable mandate. What sounds ideal is not practical to implement and sustain a operation. The cultural competency training offered in SB 365 is reasonable and will fit nicely with training required annually in NRS regulations such as elder abuse, Alzheimer's care, CPR, and a host of other trainings that personal care agencies and their employees have to go through. PCAN supports SB 365 as it is a well-thought-out and comprehensive bill, and we thank the senator for bringing it. Thank you.
Chair, we have two other members from the care world that will come up. We'll have Bob here, and then we'll have Alan Ward on.
Alan's here.
Oh, I'm sorry. Alan here, and then Bob on the, and then that would be the end of our testimony. Go ahead.
Thank you. For the record, I'm Alan Ward, owner of Home Instead. We're a personal care agency, but I'm representing the Personal Care Association of Nevada, PCAN, in favor of SB 365, sponsored by Senator Robin Titus, and regarding cultural competency training. As a personal care agency, our caregivers go into the homes of our clients for from various racial, ethnic backgrounds with different religions to serve persons with various sexual orientations and gender identities or expressions with different mental and physical disabilities. For this reason, we are in support of some cultural competency training applicable to a non-medical care provider. This training must embrace adult learning principles, adhering to the principles of simple to complex, providing these learners with an information baseline that allows them to advance to more complex concepts. This training must recognize a simple principle that adults do not like to have their time wasted. The information is presented in a time-efficient manner, 1 to 2 hours. In addition, the instructional design responds to a diverse participant population of age, gender, race, sex, education level. Our employee population is primarily women between the ages of 35 to 70 years old with grade school or high school level education, many of whom English is their second language. The level of material that was being approved by the board and the 8 to 10 hour programs left many of our caregivers overwhelmed. It became the agenda of one marginalized group negatively impacting another marginalized group of our population. Contradictory to the original intent of NRS 449103, which was to help our community become more aware of different worldviews and gain an understanding of differing cultural practices and developing positive attitudes towards these differences. The bill, SB 365, also takes into consideration the tremendous financial burden this training will put on our healthcare system, requiring 8 to 10 hours of training for every employee every year, including the average turnover that we're not considering in our healthcare system. This was going to cost our system, the state, hundreds of millions of dollars per year. And much of the cost was passed on to our fixed income seniors. This training is no more important than elder abuse training, which is an annual requirement completed in 45 to an hour each year. Just for an example, When we talk about 100 employees, that's really not a large business because many of them are part-time employees. Similar to the numbers that were run before, at about $100 a fee for the class, that's $10,000, 8-hour minimum, even at minimum wage plus contributions of 18%, that's another $100 per head. So each one's combined about $20,000. And then you consider the turnover. An average turnover across the country in home care is about 81%. Combined, you're running in around $36,000 year after year after year. This doesn't include the cost of overtime when you have the other employees fill the shifts while those attendees are in the class. SB 365 makes this beneficial training reasonable for the professionals receiving the training and fiscally responsible to our community. And for this reason, the Personal Care Association of Nevada supports the bill. Thank you.
And finally, we just have one more person, and then we can take questions.
Thank you so much. Any questions from committee members?
I think we have somebody in Las Vegas that's presenting with us.
Oh, okay.
And then we can
Yeah,
we'll
very
take questions.
Please
Thank you.
proceed.
Thank you. For the record, Bob Crockett, Crockett, Advanced Personal Care Solutions. Been providing personal care under Medicaid contracts for elderly and physically disabled for the last 20 years. Probably done about 3 million hours of service in Clark County over that period of time. We're in favor of SB 365, sponsored by Senator Titus. We've supported the cultural competency bills in the past. We're going to continue to do so in the future. But in the personal care industry, especially personal care performed under Medicaid contracts, the majority of our personal care attendants work with one care recipient. Due to a misclassification where we were put into medical facilities and other related entities, we sometimes get affected by great legislation that wasn't intended for us. SB 365 resolves some of these issues for us. At my agency, 80% of the caregivers are female, 74% of our caregivers are people of color, and to break that down, it's 22% Black, 22% Hispanic, 20% Asian, 10% Pacific Islander, so we have a very diverse group. 30% of our caregivers immigrated to the United States, and almost 40% speak English as a second language. By way of example, I've got 3 caregivers who are 78 years old or older. Those are caregivers, not clients. Each of them are Black. They've taken care of the same client for me on average for over 11 years. I could give dozens of examples like that, and we've spent the last year trying to be compliant with these regulations that require us to send caregivers to cultural competency training for 8 hours every year, which is really painful. It feels like I'm disrespecting those people, telling them they need to attend to 8 hours of cultural competency training every single year. We know it's important, but it really needs to be targeted to the 300 administrators in this state so that they can go and train the 20,000 caregivers in this state. Administrators of personal care agencies are often the people responsible for setting the cultural tone of our agencies. Administrators of personal care agencies need to be held to a higher standard. If there's a problem with cultural competency in our agency, or specifically my agency, that's my problem. I'm the one who needs to get better, and I don't feel the burden should be on my caregivers, especially those caregivers who are dealing with a person one-on-one, sometimes for a decade. I've got people who've worked for me for 20 years. I would be very much in support of an amendment that required additional training for administrators. I don't care if it's 8 hours a year. I'm more than happy to do that. We spent the last, in 2021, there was a bill in 2021, SB 340, and we spent 2022 in public hearings. It was about caregiver conditions. Representatives of agencies, caregivers, and clients, we voted unanimously that this needed to be sent back and revised so it wasn't so burdensome and targeted at our caregivers. That was a point of an agreement between caregivers, clients, and agencies. It's our hope that the wishes of the SB 340 board would be considered when you look at this bill and consider revising cultural competency training requirements in the state. Thank you.
So, Mr. Chair and members of the committee, as you can see quickly on the bill, if you have it in front of you, and I believe that we all had a copy on our table. Good Senator Wynn mentioned about a short bill the other day, and unfortunately, I don't want to make any comments about it's an easy short bill, but it is just, so you can open it up, and there's two things that we change in here. It just, the one section 1, number 2, it just says who has to have the training, and what it defines direct patient contact. And then in section 2, number 2, that the training has to apply to whatever profession you have. That training should be part of your credit, that your CMEs, your CEUs, and those type of training. Because one of the things that we did see was that, as Dr. Pintar mentioned, you take the training another 6 hours or whatever the training was, but that we already were mandated to take 40 hours, and there's a whole litany of things that we are mandated to take, in addition to whatever we think we should take for the profession, the particular field that we are in, whether it be endocrinology or cardiology. You have to do all this training for that to keep current, in addition with suicide awareness and all of those things. So that's how this bill was drafted, and I'm happy to take any questions. And again, I just want to go on record saying we are not against the training. I think it's really important. I know that the state of Nevada and regulations has put out a memo halting the regulations, now recognizing that there was no clear direction that they were going, trying to. And see, there's several bills here in the building looking at this issue, because it is indeed an issue that, again, we appreciate what Senator Spearman has spent time doing, and I've met with her. Just to be clear, I'm not trying to take away culture training. I think it's important. Thank you.
Thank you, Senator Titus. Before I let folks ask questions, I did propose an amendment that would remove subsection 3 from section 1, which would remove the 2-hour requirement. So the bill, under my proposed amendment, would be to just focus on the aspects of who is required. So it's the scope of just looking at from that perspective. So just giving clarification. And that's my conceptual amendment, but I know just wanted to give it up for folks to ask questions. As you may know, we have other bills that will talk about the hours, and that will also go through vetting processes in our committee. And so happy for any folks to ask questions to Dr. Titus. Vice Chair Nguyen.
Thank you. I'm also in a profession that requires various types of training and other continuing legal education. And then there are specific things related to ethics. And even during the course of my 21 years as a lawyer, they've added additional requirements in addition to ethics, substance abuse, mental health requirements that were in addition to those. So I understand that. I know that even during this going in my third session, we've heard bills and we've heard people come in, especially our communities of color, talking about how they have difficulty accessing equal quality of care. And I'm just curious on, it looks like you're not removing those cultural competency requirements. Or are you reducing them, or just using them in lieu of other requirements?
From a medical professional standpoint.
Name for the record, please.
I'm sorry, Dr. Susan Pintar for the record. To partially answer the question from the standpoint of the medical and nursing professions, if I could expand that a little bit, we would request that these educational hours meet the continuing education requirements of the respective boards. And so that they could be used for some of those 40 hours. They could be in addition to those 40 hours, but right now, they don't meet any of those educational requirements.
Sorry. So right now, so you don't have a problem taking those credits, you just want them counted towards other types of credits, like general credits, I guess, that you're required to take?
Yes, and I know
Hours.
you're not you don't know the specifics,
Yeah.
just like I don't know the CLE
Yeah.
specifics. But essentially, there's about 20 or so credits that you have some discretion over what you take out of those 40. And so that they could fit into there, or they could be in addition to that. Again, that's for those people who have licensure requirements. I understand the concerns of the, my colleagues here, because these are folks who do not have licensure requirements. They have a somewhat different need because they need their educational requirements to be more appropriate for their levels of education. And so that makes it a little bit more difficult process.
So, go ahead.
No, I was just gonna piggyback onto that, stating that, again, we are not opposed to the training, as I've made that clear. I think it's important, actually. But what we're trying to do is clarify how many hours it needed, which is why I left the 2 hours in there, because until we see, not that it has to stay there permanently, until we see the other bill transition, if it does transition, because right now, the programs that they put forward was 6 to 9 hours of training, and so the programs that were developed had no direction, and so it was like, okay, let's try to reel this in a little bit so we know 2 hours, and then the second component of that is if we attend a class that's mandated, culture competency training, that it be quality enough that it can go towards a CME credit as a teacher would get, or CEU as a nurse would get, CME for physicians, CLE attorneys have to take these type of things too. That we want to make sure that the programs can be counted towards the stuff we're mandated to do.
And you had distinguished in, like, are these credits like how, are there any other types of credits? I guess I'll talk to, I don't know, you don't have every single, like,
Right,
person
so-
applies to, but for example, like, I'm required to take 10 continuing legal education credits of general, like,
To be-
topic, and then I have to take 2 of each of those, like, specific ones.
To be as a board certified family doctor, you have to take so many credits in different subspecialties, internal medicine, pediatrics, OBGYN, and so we have to take more than what the state requires for licensure. And so we can get in the credits, you can get states from the American Medical Association. By teaching, you get a credit. So there's things, reading certain journals, you can get a credit. But they're not, so there's a certain amount that are specific to what your field of practice is, and a certain amount that are general, and then there's a certain that are mandated by this body. And there's a long litany of things that are mandated by this body. Suicide awareness, drug abuse awareness, so all the physicians, all the providers have to take those.
No, I appreciate your candor, obviously, and your information. I know that you guys all know your particular field, so I just wanted to know which was mandated, and if this was one of those things that was mandated by the legislature that is separate from like that, like the other, items that you had mentioned before.
Thank you so much. Okay, any other questions? I have questions. Really quickly, for the presenters, if they can remind me which scope of facility you work in?
Dr. Susan Pintar, I'm the medical director for an ICF-ID, Intermediate Care Facility for the Intellectually Delayed, which we are the only one left in Nevada.
Thank you, ma'am.
Alan Ward.
One second. And how many employees do you have? That would be helpful too. Or in
There
your
are about
organization.
100 employees within our facility.
Thank you.
Alan Ward. I represent the Personal Care Association of Nevada. So we are home care providers, non-medical home care providers. And we have 8 hours annually. It's hours. It's not CEUs. It's hours that our caregivers need to take. Part of that has to be elder abuse. That's typically 1 hour. This is additional to. And what we've gone through is it's become 8 to 10 hours of training. It's very high-level
In
training,
addition to your other 8 hours.
right? But it's very high-level training for the education level of our employees.
And the number of employees that you have in your facility or that work
Not
for
in a
your-
facility. We go into the homes of our
Right.
seniors.
Well,
yes.
I mean, for your
For my
for your-
business?
Yes, sir.
I have 2 Homestead franchises. We have about 100 40, and those are part-time though. So a lot of my caregivers are working 20 to 32 hours. So there's a lot of them, but everyone has to be done. With the turnover, the national turnover in our industry is about 80% annually.
What's the average retention for your employees? How long does that, do you know the life cycle?
Well, I've got employees that have been with me for 16 years. It varies, but more lately, the turnover happens very quickly, the first 90 days to 6 months. However, it's always been a challenge in our industry. Turnover it's a tough job, being a caregiver.
Thank you, sir. The other presenters, facility type or industry type, company type, and how many employees, if you can guesstimate? I know there's some folks in Las Vegas.
Bob Crockett. Oh,
Yep.
sorry.
Please,
Yeah,
please
sorry,
proceed.
for the record, Bob Crockett, 300 employees, personal care in the home.
Thank you, sir.
May I just say,
Name for the record, please.
Alan Ward, the majority of the providers of home care are small business owners. They might be part of large franchises, but they're independent owners, small players. There's not margins in it that you would see in hospice or home health that are national or regional companies. These are small business owners. And most of them have maybe 25 to 45 caregivers.
Thank you. Okay. So the reason why I was asking that was because, so I work in primary care, and it's obviously a different level of service as well. And first of all, I just want to thank you all for coming with this proposal. I think it's important to have the discussion. When I was talking to Senator Titus on this bill, she had mentioned that in some ways what's happening is there's an extension of folks that perhaps aren't employees of the facility, but because they have touch points with the facility, that's where it becomes difficult. And so I wanted to make sure that I understood, if you did work in a facility, what is a facility type? And if you didn't, what's the model that you operate under? Personally, I actually refute the idea that caregivers should not go through cultural competency. I know that there's like some nuances in the presentation about that. I think that regardless of how diverse your workforce is, I'm a Latino, but I still have to understand what the generational differences are between folks that are probably a different age from me. That's cultural competency. If they have, say, even for me, communicating with older Latino folks, there are cultural differences that exist. Me speaking to a black patient, there are cultural differences that exist. And even if I understand what racism feels to me, it's obviously a different circumstance because I have never lived in that experience. And so I want to make sure that I refute that idea that now the question is, what is appropriate for each type of provider or person who's delivering care? I think that is a question that could exist, right? Is there a level of training that should be more comprehensive for providers that are more front-facing versus folks that are just doing routine? I think that's an appropriate question to ask, and I know that in other bills we'll have that conversation. But I just want to make sure that, if you have some level of care, or that if you're providing some level of care or you're supervising, there should be a level of extent of how you're understanding the patients that you're serving. So I want to just ask a quick question. So what happens in the scenario where, say, you do not fit the definition of this bill, which is you're not an administrator and you don't touch a patient once per week, but you still work, say, in the facility and you are making decisions that impact the healthcare delivery. Say I am I am a staff member that has to write the report of the community health needs assessment for my facility type. I should understand the requirements and what cultural competency is. Should there be a requirement for those individuals, even though I don't touch patients? I just want to make sure that I understand where does the limit stop?
Senator Donati, Alan Ward for the record. I believe that you do have a cultural competent employee, a cultural competent caregiver, and a cultural competent organization. So I believe that, yes, everyone in that organization should have some cultural competency training. I think, as you said, what degree? When you're talking about a clinical or medical, that might need more, especially when you talk about transgender and some other areas like that, as opposed to a non-medical provider. But I do agree, at least in PCAs, we look at it from a perspective of cultural competent caregiver, cultural competent employee, and cultural competent organization as a whole. And that's where Bob was talking to. The administrators also have to be well-educated and maybe more educated on a regular basis.
So then my follow-up to that, and maybe this is for any of the presenters, who do you believe should not be taking the cultural competency requirement?
Maybe
Bob Crockett, for the record. And at least as far as I'm concerned, the father of children of color, one of which is a happily married gay man, everybody should take cultural competency. I think from our point, it was 8 hours a year for some of these people. It is a little over the top for personal care. Thank you.
I understand that, but the bill with my amendment does not talk about the hours anymore. So if we're going to accept the amendment and we're only talking about the scope of who is required to take the cultural competency, because I think that's also some intentions of the bill, who would you, in your facility or the employees that are employed by your work, who do you envision not having to take the cultural competency requirement?
Can I answer?
For the record, Bob Crockett again, everybody should take it.
Alan Ward, for the record. I don't know, but you've got car parks, people who are valet parking at the hospital. Do they need to take it? Maybe they do. They aren't really engaging from that perspective like you would engage as a retail, provider or a restaurant person. I'm not speaking for that industry. I'm really speaking for PCAs, and within ours, the majority of our employees are engaged in one way with the family or the client. So in our facility, I think everybody should, like I said.
Dr. Susan Pintar.
Yes, ma'am.
I think to address that, again, from a little bit different perspective, an institutional perspective, we are not opposed to all of the employees receiving the education that's appropriate for their level of patient interaction and educational level. And that's one of the things that the current requirements, they paint a very broad brush, and everybody has to be underneath that. So for many of the staff at my facility, this training was overly simplified because they tried to cover about 35 different topics and gave 5 or 10 minutes to each one. But for others, it was totally overwhelming because their level of education was not such that they could understand the basics of it. What I think is much more appropriate is to allow the institution, with the oversight perhaps of the State Health Department, to decide on the type of education within a bigger selection, shall we say, of cultural competency education. So what might be more appropriate for Mr. Ward's employees may not be appropriate for my nurses, but it might be appropriate for my patient care attendants.
So thank you for all the questions. Thank you for that in general. Looking at the bill itself, it talks about the requirements of subsection 1 applying to any agent or employee of a medical facility for the dependent facility, which is otherwise required by regulation to take this. And then it defines it would be anybody who administrates those folks or anybody who comes and has direct patient contact at least once a week. So that was put in there because if somebody just, but I also see that where you are, and we are, I'm happy to take that out because I think that anybody who has direct patient contact at any time should have cultural competency training. I'm not against removing that, but what we were looking at with that amendment or that correction is the folks that drive up to and deliver to refill the candy machine, the Coke machine, the contract people, the laundry people, the people who drive onto the facility. And in my mind, the people that don't have direct patient contact, but they do come on the grounds, but they don't have anything to do with the patients. They come to the lunchroom, they deliver the cans of beans to the kitchen, to the cooks, but they're not in that building they shouldn't have to take any of this stuff. And so that they wouldn't have that direct patient contact. So whether it's a week or a month or any patient contact, if they're involved with patients, I certainly believe that they should have the training. But it was the onus of it was unclear who has to have this training. You contract with the guy who does your uniforms, your surgical scrubs, all of that. Do they have to have the training? They never see a patient. And so I would be some concern with that, and that's something that you actually, Dr. Pintar, had brought up to me.
Yeah, the current language, Susan Pintar, the current language is any agent or employee of a facility who provides care to a patient. And that, again, is that very broad brush that I think is difficult to meet.
Thank you. I think in the reason why I was asking that was as I'm thinking about particularly section 1(2)(a), where it says provides clinical, administrative, or support services and has direct patient contact. What I was trying to allude to is, what if I make decisions for how contact is delivered, but I'm not the one that's being influenced, right? Or sorry, I'm not the one that's actually touch pointing or delivering it. So I think the easiest way to cover that would be you could switch it to provides clinical, administrative, or support services and has direct patient contact or influential, or like has some level of influence on direct or on patient services, or whichever how we wanted to name it. That way you can also capture those folks as well, because I think there is a correction where where I see the merits of the bill is you could perhaps, I think there should be more comprehensive trainings for the folks that are directly involved with the care of the patient, right? I think physicians should have a deeper level of training, APRNs should have a deeper level of training, because they're the ones that are actually face-to-face interacting with the patient all day, versus what I think what you're alluding to, there might be some staff that are currently covered in statute where the nuances probably need to be revised, and I think that was the portion of what my line of questioning was. But I still believe, I still think that regardless of, I've received emails about it, regardless of how diverse your staff is, I think you should all, cultural competency training is important for everyone. So, and I think that was, I know that the presenters made sure that we
Yes,
agreed
I
to
don't
that.
think anybody does not support cultural competency.
Right.
And that is the underlying principle. What we would like the education to be is applicable to what you're actually doing, so that you could be useful for you.
Yep. Thank you so much. Senator Titus, did you have any closing remarks before we go to testimony?
No, I'll have closing remark after the pros, cons, and thank you.
Thank you, ma'am. All right, let's go on to testimony in support of this bill. If you support this bill, please come forward. We'll cap testimony to 2 minutes each.
Good afternoon, Senators. Joan Hall, representing Nevada Rural Hospital Partners. Certainly, this bill, as it was first written, needed clarification. Everyone understands that cultural competency is important. There was confusion, I think, not from the bill itself, and I appreciate what Senator Titus is trying to correct. It was actually the regs that caused the most confusion. That's where the problems, really arose. There was difficulty getting courses approved, the timing of the courses were different, and the educator to provide the courses were very different. So I appreciate the fact that this limits it and gives us more definition. Certainly all hospitals believe, as you said, cultural competency is important to be educated. We should all have it. Thank you.
Ms. Hall, I think Vice Chair Nguyen has a question for you.
Okay.
You mentioned the regulation and the regulatory process. So when did these go through, like, the regulatory process, and did they go before the Ledge Commission? And
They did.
Like, were
I'm
there
not sure if they
just-
went before the Ledge Commission, but yes, they were regulations that were adopted. Facilities took 5 or 6 times. Some facilities, after this bill was passed originally, have still not had their courses approved. They've been relooked, and for various reasons not been approved. The courses that have been mentioned, the 9-hour course is something that AHEC put together. It's a very comprehensive course. It's very good. It's also very expensive, and as was discussed, 9 hours for every employee is very difficult for large hospitals. That's a lot of time. So that was an issue, but those regs, in the governor's discussion about unneeded or unnecessary regs, I think those are the ones that have had the most comments. I believe that those are going to be removed.
Do we know why they were being rejected? Like, if it seems like it was, like, were we given reasons why they were rejected?
I think it depended
Sorry, I
on-
know I have a lot of questions,
That's
mostly
okay.
because I'm not familiar with some of these things, but now you're bringing up this whole regulatory process. So-
Joan Hall for the record.
I'm slow today, but I'm putting it all together that we're bringing this bill because it's taking so long in the regulatory process. So go ahead.
So, yes, Joan Hall for the record. Yeah, it's worth the discussion. I think it is going to be corrected without the regs. There was not a lot of rationale for the reasons that courses were denied. In fact, several of our hospitals tried resubmitting one that the other hospital had approved, and those approved courses were denied for a different facility. So it was it was very frustrating, like your facial expressions say. The educator also was not always approved. So it became a very difficult process. Then last session, there was a bill for relicensure. As a nurse, I would have to take an approved course by the State Board of Nursing to be relicensed as a nurse. But that course didn't match the course that the hospitals gave. So there was this real disconnect. So HCQC is aware of this and working on it, and as I said, the regs, I think, are going to be removed. But, and I think what Dr. Titus is trying to do with this bill is show who, because some of the who was also a concern, and the number of hours.
Thank you so much. I think we'll just continue with testimony, please, so we can wrap this bill up. And all right, testimony and support, please come forward.
I'll stop asking questions.
At the fear of walking in a minefield, I'm Barry Cole, B-A-R-Y-C-O-L-E. You know who I am. I'm a old psychiatrist. Hey, in February, we did 8 hours down in Las Vegas for our State Psychiatric Association. One of the issues that I'm beginning to detect is that some of what SB 365 is trying to define is what will count, because we didn't get approval from the minority coordinator of the Department of Public and Behavioral Health. We went through Melissa O'Brien, the CME coordinator for the University of Nevada School of Medicine. We got 8 hours approved. I'm not even sure if those 8 hours would meet any of the old requirements. I get that under the new bill, we're talking about 2 hours. We thought we gave a very rich curriculum. My comment would be, I've lived in Mexico for 3 years, quite literally. I went to medical school there. I've led people-to-people delegations all over the world, literally to Tibet, to China. I've done consulting work throughout Southeast Asia and Latin America. I'm not sure what diversity training I could receive that wouldn't help me kind of get past what I already think I know. And that's the problem. I think that these courses, my colleagues tell me all the time, they just don't feel like these courses are answering any of their questions. We all know we have biases. If it weren't for xenophobia, and I hate to use that word, I guess none of us would be here today. We instinctively have always feared the person on the other side of the hill. And if you think about it, in the Viking days, they came and they burned your village and they stole your children and your women. So there's a long and brutal history we're trying to overcome. And certainly being the descendant of 3 grandparents who were immigrants, and if you went back for the 4th, a generation before, she would have been an immigrant. I feel like there's a lot I need to learn, but I'm not even sure how much I'm not even sure
Thank you,
what's
Dr.
approved.
Cole.
Bye.
Appreciate you, sir. Any other folks in support, please come forward, and we'll go to Las Vegas.
Hi, good afternoon. My name is Ron Zumbang. I am the chair of ECHO, Adult Residential Care Providers of Nevada. It's another type of providers. We represent the care home, commonly known as group homes, but we love to call ourselves as care homes because we care. Anyway, I share the sentiments of everybody who spoke ahead of me on a lot of perspective. One, it has to be, again, for the record, we support cultural competency, but how it is applied to each and every entity or type of providers, that's where the question comes in. Like, for example, with our type of service as a care home, like I heard somebody mention about the educational background. Right now, what's going on is it's just more of compliance. Okay, I'm going to attend the training, 9 hours, 16 hours, or whatever. But are we really absorbing what cultural competency is teaching us? It's so clinician. The terms that they use, the verbiage, the idea that they present, is it appropriate for the type of services that we provide? So those are the things that we need to look into. Plus also the costs. The costs, when it first came out, everybody was complaining. For one, compared to other states, we are one of the lowest as far as rate of reimbursement is concerned. That's an additional expense for each small business owners, facility owners. We're not corporate type. We're just mom and pops type of services. Another thing too is yeah, I lost my thought. Sorry, I lost my thought. Another thing too is
Thank you so much, sir. If you can wrap up your comments, please.
Sorry.
Hi. Oops, I forgot. Hi, Katrin Ivanov, Ivanoff for the record, aka Mrs. Fixit. I am from Assembly District 42, Senate District 9, and I am I'm here to express my strong support for this bill, and I'm just going to say ditto to everything for the sake of time, and I would yield my time back to the previous speaker. Thank you.
Thank you very much. For the record, Ron Sumbang of ECHO. Yeah, what I'm about to say is that...
Ron, we've already gone through
Yes,
your
sir.
testimony, so unfortunately we're going to have to move on, sir.
Okay. All right.
But you can submit your testimony in writing, okay?
Okay, all right.
Thank you, sir. Anyone else in Las Vegas?
Ditto, yield.
Name for your record, please.
You know.
Name for the record.
CYRUS. Thank you.
Last name?
HOJJATY.
Thank you, Cyrus. Anyone else in Las Vegas? All right, we're going to move on to the phones. BPS, is there anyone in testimony and support?
If you would like to testify in support of Senate Bill 365, please press star 9 to take your place in the queue.
Casey Rogers for the record. I'd like to just echo what the old psychiatrist, end quote, because I didn't catch his name, I just caught that, had said. And I just feel like there's a lot of costs going into certain things like cultural education, diversity, equity, inclusion education is like $3.4 billion is an estimated cost. And they're actually finding that people are actually less willing to interact with people of other races, other cultures, and things like that. It deserves a really good study on that. So yes, I'm in support for this bill, and that's all I think I needed to say for right now. Thanks.
Hello, my name is Zachary Gray. My wife and I own Revive Health Senior Care in Northern Nevada. We own 3 nursing homes and represent 550 employees. We are calling in support of this bill. We are in support of cultural competency training. However, the last year has been an absolute nightmare in terms of the administrative rollout and administrative oversight of the cultural competency program. We've spent over $55,000 attempting to train our employees and comply with this program. This bill gives some much needed clarity on how the program could be administered, and we appreciate and thank Senator Titus for sponsoring it. That's all I have to say. Thank you.
Chair, there are no additional callers choosing to testify at this time.
Thank you so much. Anyone in opposition in this room, please come forward. And we'll start the timer for 2 minutes.
Thank you, Chair Doniate and members of the committee. My name is Steve Messenger. I'm with the Nevada Primary Care Association, representing the state's federally qualified health centers. But today I'm here to talk a little bit more about a program we have at the association level, which was the second third-party product approved for the health facility training in accordance with NRS 449.103. So we've thought a lot about this. We've been doing this for several years. We've done hundreds of trainings. We've worked with lots of organizations. We train trainers in organizations. We work with them to try to find, ways around this. We know very well that the policy needs to be updated here. I'm here in opposition to the limiting it to 2 hours per biennium. When we get that amendment through, I would be very interested in working to kind of, from our perspective, think about how do we marry all the different stabs at cultural competency that we've got going, and what is the most appropriate, because we absolutely agree that there's a lot of duplication between having to take this 9-hour course, having to take now all these CEU courses, and some are going to match, count for some are going to not count for the others. But it all needs to be coordinated so that we can have a reasonable amount of time every year that these people are doing. And it needs to be so that we can bite off those chunks and that cycle actually makes sense, such that they're getting the training at whatever frequency we determine appropriate, as often as they should be. So with that said, I do have a lot to say about the regulations too. There's a lot that could be done at the regulatory level, and we would love to work there too. But just in defense of cultural competency for 1 second, there's definitely still health disparities in this world. And we know that working in a culturally incompetent setting not only affects the patients, but affects the workforce there. It can affect what goes on to become our health workforce in Nevada. And if it's driving people out because we're not competent in our facilities, then we're going to miss out on the population that's going to take the providers that are going to take care of our population. Thank you.
Hello, Chair and members of the committee. My name is Vanessa Dunn, VANESSADUNN, with Bells and Case Government Affairs. I am here on behalf of the Nevada Public Health Association. NPHA is standing with NVPCA. NPHA opposes this bill that will roll back the cultural competency requirement for facilities in Nevada. All Nevadans deserve to be able to access care in places that acknowledge, accept, and care for multiple cultural identities. Thank you.
Thank you so much. Anyone else in opposition here in Carson City? Anyone in Las Vegas? And BPS, anyone virtually?
If you would like to testify in opposition to Senate Bill 365, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much. Let's move on to neutral testimony for this bill. Anyone in Carson City? Anyone in Las Vegas? And anyone virtually?
If you would like to testify in neutral for Senate Bill 365, please press star 9 to take your place in the queue. Chair, there are no callers choosing to testify at this time.
Thank you so much, Senator Titus.
So thank you, Chair, and members of this great committee, and thank you for those who testified in both in favor and against this bill. I think what the resounding conversation is that that this body, not uncommonly, will pass bills with great intention, only to recognize that we needed to clarify what we do and how to implement it. And so with hope with that, we can yes, I'm more than happy to look at this bill, amend this bill, improve this bill, because clearly from all the testimony, the bills were passed without a clear direction, and we need more guidance, because one of the things what we don't want to have happen is that people do not take these classes or these courses, or they become resentful about it, and then that actually ruins the whole reason why we're doing these courses, because we want access to care, we want everybody treated equally, and as my colleagues and I have discovered, perhaps the best training would be to do training that mandated implicit bias training, because we in Nevada see so many cultures. We're probably the most culturally diverse state in the nation, not only from the folks who choose to move here, but the people who visit here. So can we teach to every culture that we might see? Perhaps not, but maybe we have better look inward, and maybe that would be the best thing that we could do, and work on that implicit bias. And I don't know that is part of any of these programs. So with that, I thank you all for your time. I thank again for all those who are for and against, because you're here because it needs some clarification. So thank you very much for your time.
Thank you, Senator Titus. At this time, I'll go ahead and close the hearing, and we'll move on to the last agenda item, which is public comment. Is there anyone here in Carson City? Anyone in Las Vegas? And anyone virtually?
You would like to provide public comment? Please press star 9 to take your place in the queue. Chair, the lines are open and working, but there are no callers choosing to provide comment at this time.
Thank you so much. Before we conclude, we have posted, we're going to, if we haven't already, we're going to have a work session possibly tomorrow at 1 p.m. So just be aware that agenda, if it hasn't already been posted, will be posted fairly soon. So thank you so much, and the meeting's adjourned.